We go on to Dr. Nivean Madhivanan. Nivean is, I would say, the rising star of Indian ophthalmology, and he's got several innovations. Fantastic surgeon, both anterior and posterior segment surgery from MNI Hospital, Chennai, and he's going to talk to us on secondary IOL, that is the iris claw lens, and also his own innovation, which is called the CMT Flex lens. Nivean, all yours.
Thank you, sir, for those kind words. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to talk about first the retropupillary iris claw lenses, and then new innovation that's a CMT Flex IOL for aphakia. So, I already saw a lot of hands raised. So, these iris claw lenses were invented by Wurst. He was inspired by those lobster claw. So, it's a relatively simple design. It's a single piece lens, no additional loops. So, basically, it works on the mechanism of enclaving the iris tissue. Two instruments that are very key are the forceps that are used to hold the lens, because basically it has to be slightly broad, because these lenses, when you're trying to clip, when you use the regular IOL forceps, it can slip. So we have the crocodile forceps or the iris claw forceps. It's got a broad tooth, so it gives you a firm grip. And also always check sometimes, because sometimes the area is not fully cut through. I have had many incidences where you've gone inside and then you're multiple times attempting it, and that can cause damage to the iris. So just check the lens and make sure where you're going to clip before you put it into the eye. So we'll just go through the first case scenario. As already described, for any of these secondary IOLs, the most important thing is the vitrectomy, anterior vitrectomy. Make sure you clear the vitreous before implanting these lenses. Since it's a rigid lens, we make a sclera corneal tunnel. As you can see here, that where you're going to clip that 0, 180 degree, even an iris claw. You can do it anywhere you want, but make sure you have the 180 degrees entry. Once you stain, I always prefer to stain and wash it. You can see the amount of vitreous strand. Even though it didn't look in the starting of the case, it looked like a round pupil. It was all good, but then once you stain, you see the vitreous. So you can use a side port. This particularly I've used the trocar, but you can use an AC maintainer or have the infusion through your side port and the 23 gauge or a 20 gauge cutter that comes with most phaco machines. So once a thorough anterior vitrectomy is done, and make sure all the strands are clear, make sure the viscoelastic is put to, and make sure you position the lens where you want to clip. The second tip here is I usually take my second instrument also inside first to the mid periphery of the iris where I'm going to clip, and then take the lens inside. So by this what happens is I know exactly where I'm going to clip, and that's where I'm actually taking the lens. The second thing is your right hand has to move up and your left hand goes down. So this happens simultaneously. So when this happens simultaneously, you see the tug and you can see a small dimple that happens. So it's going on to the other side. Again, the firm grip in the center is very important. My second instrument is already there in the mid periphery. Why? Because sometimes if we go anterior, that is when you get this cat eyes kind of pupil, and sometimes if you go too posterior, you can damage the roots and cause bleeding. So again, I'll just show you in slow motion in this video again here. So making sure the firm grip, my second instrument is already inside, and then take it to where you want to clip. Yes. And that movement of one hand going up and the other hand going down. So there, just going inside, making sure you know where you're going to clip, because when you push your lens, you can actually see that iris lifting up. So that makes it easier, and you don't have to give too much of force actually. It is just some amount of partial tissue that gets enclaved here, and you don't have to have the entire iris tissue going inside. And you do get nice round pupils and moderate amount of dilatation to see the post-op fundus, because there was a lot of debate compared to the other lenses. So, and you can use these lenses also vertically also, because this was a case where it was a long-standing aphakia with glaucoma. So the glaucoma surgeon did the trap superiorly. So we had to shift temporally to make the tunnel and do the claw lenses. So here in these types of, sometimes you get these rigid pupils due to long-standing aphakia. So here again, don't be forcefully going inside, because that can damage the iris and we have had bleeding. So what I do is, once you hold the lens here, use your second instrument to guide the lens under the iris, just by stretching the iris, because I have a lot of instances where people try to just push the lens down below the iris, and that can cause damage to the iris and cause bleeding. So just use your second instruments, you guide it and then go inside and then clip it. And as a routine, we have a large publication on the long-term follow-ups of these claw lenses. We do not, the incidence of glaucoma was comparable to other SFIOLs, so we don't routinely do PI. That was another question raised. So what we have found is sometimes too much of viscoelastics when you use during the surgery, or leaving out some of the vitreous was the reason. So yes, complications are there. You can have iris tears, non-clipping of the lenses or breakage of these lenses, and we have also a lot of publication comparing with other SFIOL techniques. But done properly over a period of time, I think you do get very good results. And for on-table complications or in small incision cataract surgeries or in training institutes, I think this is a very good option of an SFIOL along with all the other techniques. So now moving on to the next part of the talk is the CMT Flex IOL. It's a new option for aphakia, so no financial interest. So basically it's a single piece hydrophilic lens with specialized T-shaped haptics on either side. So the whole concept is when you pull out these haptics through the sclerostomy, they just open up and stay there. So this avoids any tucking, suturing or gluing of these lenses. So here again we have a case of an aphakia which was referred to us. So as for any SFIOL, the 0-180 degree marking is very important. So we use the Ashwin's glue IOL marker to mark the 0-180 degree after making the peritomy. So we make partial thickness scleral flaps on both sides. We make a 2 by 2.5 partial thickness scleral flaps using the crescent blade here. So why this 0-180 degrees? Because basically it avoids any tilting of the lens or any torsion later. So 1.5 millimeters away from the limbus, we make a sclerostomy using a 23 gauge needle on both the sides now. So after doing the vitrectomy, as I said, and removing the remaining cortex, so we have specialized T-flex forceps that goes through sclerostomy. The other advantage of these lenses are being a foldable lens, you can make your corneal incisions wherever you want diagonally opposite. So this makes it easier to feed the lens. Initially we were always doing superior, but then you have an angle of 90 degrees that has to be, so this way it makes it easier. So make sure that the T haptic comes out first, so it is easy to grasp it. So now what we call later on after 5 years of learning is we call this as the head-on position. So basically what happens is when this comes through sclerostomy, the haptics bend inwards. So there is lesser portion of that CMT flex lens that comes out and that makes it smoother. Initially we were holding the neck here, so it's a bulkier portion, so people used to tell that sometimes during pulling out it slips or breaks and you have to use more effort. So we call this as the head-on position. The second trick is, since it's a single piece lens, inject the remaining of the lens after holding it. So otherwise it again can detach. So make sure you have the trailing haptic at the wound or over the iris. And once the lens is free from the cartridge, then make sure that you pull the haptic out and then you see a pop and the T opens up. So once that is done, it is literally over. So just a small animation, it can be done with any regular IOL cartridge. But as I said, just make sure that the T is just pushed inwards so that when you inject, the T part comes out first, and that actually makes it easier for us to hold and grasp. So there's no special cartridge or anything that is required. And clear corneal incisions, so if you have an old scleral tunnel, you don't have to open up the tunnel and suture again, so you can make a fresh clear corneal incision, and that's how it is. So now for the second thing, we use the handshake technique. So using the other Nishi forceps, we usually grab the arms of these lenses. We also have two holes, so that actually indicates which side the lens comes, because we have an angulation, like a 10-degree angulation between the optic and the haptic. So that basically that angulation prevents any rubbing of the iris or any pigment dispersion or glaucoma later on. So once the second hand is exchanged, that is also brought out. So as I already said, because of the specialized haptic designs, there is nothing more you will have to do. However you mark your 0-180 degrees, that's how the lens is going to stay inside these IOLs. And you can see you have nice round pupils. This is just to show you how it is. And we close the scleral flaps. So initially we were actually gluing the flaps and the suture. You can either glue it or you can use your suture or even just cauterize it, because here these haptics are slightly thicker. They are not the 3-piece lens haptics where you might have leakage because you're using a 23 gauge sclerostomy. So you don't have to actually glue it, because the size of those things are make sure that it fits the 23 gauge sclerostomy perfectly. So there's not going to be any leak. So these are some of our studies on UBM just to show how the position of the lens in compared to normal PCIOL or the other secondary SFIOLs, and also OCT images through the sclera just to see the long-term efficacy over 5 years, how these material actually behaves under the sclera, and our publications are out. So the other thing is it can be combined with any other technique, like any SFIOL when you have a traumatic iris, when you want to do a scaffold technique. So this is just another case where there was a trauma and there was like superior hydrodialysis. So again, as I said, 0-180 degree, the ease is you can actually go vertical, you can, wherever you have the area where you can see. So that's another advantage here. Again, just 1.5 millimeters away from the limbus. As you can see these holes, some of the surgeons have told me that they use these holes with the dialer when they want to exchange to the other hands. Some of them have been using the Hoffman's pocket to do this and deliver it, so then they don't have to make the flaps. Or sometimes we also do a groove. So basically, as long as the haptics is under the sclera, it is safe and it is better. As you can see, the other side is exchanged and then brought out. At the sclerostomy, there is going to be a slight tug. That is because of the instrument diameter. So what I suggest is you don't actually whack it out, because that again can actually release the hole. Just wait at the sclerostomy end and give a constant pull, and you can actually see it slipping out rather than just trying to pull it out. And then we did an SFT for the superior iododialysis. Yes, for the anterior segment surgeons, yes, it can be done. It's an alternative again. So the last video is going to be that. The only thing is always use an AC maintainer, because for any of these secondary IOLs, the biggest problem is hypotony. So this again, you can see a post complication of SICS in an asteroid hyalosis case. We know that sometimes the bags are weak. So here we are just doing it through the anterior approach. So ideally you should have used an AC maintainer. So, but again, because it was formed and I didn't use a lot of viscoelastics. So again, here we are just making the grooves. We didn't make the full flaps. So there are just various modifications of the same technique. So again, now once the lens is injected inside, I always just open the flap just to make sure when I have the tug and I'm able to see clearly. That's why I lift the flaps before I pull the T junction out. Here again, exchanging the other hand, grabbing either the head or the neck, either way, and they are relatively flexible, so less intraocular damage to the tissues also. And they have a good stretchability also. We have titrated the water content in such a way that you have some amount of stretch that also happens, that prevents any breakage. And always check if you're not sure that is there any vitreous left behind. So you can always introduce tricot and then wash it away just to make sure that there is no vitreous, because post-operatively any CME that is going to come is all because of the leftover vitreous, and also some amount of this tricot actually goes behind and prevents post-operative CME. So that's another advantage of using tricot assisted vitrectomy for all your cases. Yes, complications can happen. As I said, it's common for any SFIOLs. You can have breakage of the haptics, or when you pull forcefully, the other side can slips, or the other things, isn't it? So it's been a long journey from the time of invention. It's been almost 7 years follow-up we have. Thanks to COVID, we had lost 2 years of bringing it into the market. But thanks to Dr. Mohan Rajan, Amar, and everybody who helped me in this journey to bring the lenses today. So thank you once again to everybody.
Oh, very nice. Nivean, I think is a very beautiful presentation. Sugas, you have a question? We have some time for discussion. I think it's a very beautiful innovation. Come to the mic, Sugas. Nivean, come here.
Compliments, Mohan Rajan. Beautiful course, and congratulations to you for very nice innovation. In fact, for most of us, a simpler technique like this would certainly be good. My only question was, in the iris clip that you showed, I mean, the general understanding is, when you want to do a retrofixation of an iris clip, if you have some remnants of capsule, we normally try to get it out, because otherwise, through the capsule and the iris, if you want to enclave, it is difficult. But in your first case, I saw the entire rim of capsule. Whenever I see that, I cannot do it because
absolutely,
lot of thickness. Can you just throw
it's a very beautiful observation. Only people like Suhas can notice it. But I'm just telling you, any secondary IOL, okay? You saw that there are many ways to skin the cat. That's a different issue. But any secondary IOL, please remove the vitreous, number one. Okay? Some of the posterior segment surgeons say that we should do a complete vitrectomy, do a PVD also. It's not necessary. It's not possible for all the anterior segment surgeons to do it. Remove all the capsular cortical remnants. Suhas, I perfectly, fully agree with you, because if you have a glued IOL or a sutured, this will go and stick there and produce a lot of adhesions, a lot of traction on the vitreous base as well. And iris claw lens also, if you want to have a capsular remnant, you do not know whether it's fixing on the capsule or fixing on the iris. So it's going to be a problem. So remove all that. Make sure that the area is clear completely. If the pupil is small, use iris hooks to dilate, as I told you. Amar also showed that. Use iris hooks to dilate. And the game changer, in my opinion, is not viscoelastics in secondary IOLs. Have a anterior, it's only a fluid into the eye, because that can prevent hypotonia, because viscoelastic can go and mix with the vitreous, and HPMC can go and mix and produce severe vitreitis, secondary glaucoma, and all these problems can occur. Use either an anterior chamber maintainer, or if you are conversant with your pars plana, you can put a pars plana infusion as well. So anterior chamber maintainer is definitely more, much more better for an anterior segment surgeons. You can either use a trocar anterior chamber maintainer or the anterior chamber maintainer which Sujata had shown. I have also developed an anterior chamber maintainer with Appaswamy, which is available with just a 23 gauge needle with a biflow. So you can just insert it like that into the cornea. Just make a small tunnel into the cornea and just insert it straight away with the needle. It's called the needle ACM. So all these I think is very important. Ashraf, you would like to make a quick point, then we go to the last talk. We have some time.
A very good observation, really, because I was looking for this case. We cannot put either iris claw lens or scleral fixation IOL without removing the whole bag. It cannot be like this, unless Susan Jacob, I think, invented the supracapsular.
I've seen that video, but I feel,
Yes.
but leaving those capsular and cortical remnants there is going, because it produces a lot of additions, lot of inflammation,
Exactly.
and you don't want that to happen, because the glued IOL, the problem is we do not know what's happening underneath the iris in the ciliary body area. So better to remove everything, clear it up. Yeah, that's a take-home message I want to give everybody here. Yeah, Nivean?
Yes, I totally agree with you. That's the clear take-home message, and that's how we do it. This particular case was a 12-year-old aphakia. We are always used to try to remove the capsular bag using the forceps. When I tried that, it was coming along with the iris, so I didn't want to cause any iatrogenic tears or bleeding, and that's why the entire iris was weak. So as you said, your take-home message is that make sure you clean the bag, the cortex, the vitreous, and then do any secondary IOL implantation. But very rare few cases that sometimes only in the old cases. I don't see anything in the recent cases that we leave it like that.
But CMT flex is something which is, I think, is really a fantastic